much, and probably I'll call you after some weeks, because we keep on meeting all these things. So now we will be going ahead with the several more presentations. So whatever time you can sit down, you please sit down, because now I'll invite Dr. Abhishek Agarwal. Dr. Abhishek, you are here. Dr. Abhishek Agarwal. Dr. Abhishek Agarwal. Yes, please unmute yourself and share your screen. After that, Dr. Bharti Malhotra, Professor and Head of Microbiology, will be speaking. Dr. Sheetu Singh, Dr. Prerna Singh, Dr. Ravindra Rao, Dr. Raghav Shah, and Dr. Ram Gulati, and Dr. Pankaj Verma. All 5 to 7 minutes presentations each, and very interesting. We have got it prepared. So, Dr. Abhishek Agarwal, just unmute yourself. Abhishek, can you?
Yes, sir. Yes, sir.
Yes.
Am I audible now, sir?
Yes, now you are audible.
I can see many stalwarts here. Good evening, Dr. Maniar, sir. Dr. Gangakhedkar. Dr. Gangakhedkar has, I think, covered every aspect of COVID management, including vaccination, how strains are going. So it has been covered wonderfully. So I will not take much time, and I have a brief presentation, and I will run through it quickly. So I know everybody is waiting. So can I share my screen?
Sure.
So I think it is visible to everyone.
Yes, it is visible.
Yes. So I will. My presentation is mainly in two parts. One is how the second wave is different from the first wave, although Gangakhedkar sir has covered everything. So now bear with me. So COVID-19, the changing face of epidemic.
I'm muting all. So once if you find yourself muted, please unmute yourself. Abhishek, now you unmute yourself, please. Yes, and start speaking.
So, am I audible now?
Oh, yes, you are very well audible.
So, as we all know, and from the last presentation, the things are very clear now. So, we have many strains. Double mutant strain is there, and the UK strain, Brazilian strain, South African strain, and now even we have got a new strain in Visakhapatnam. We heard about it 2-3 days back. So it is as the virus is rapidly mutating, we are getting new strains, and they are having different ability to spread disease, and they are having different virulence. So the new virus is highly infectious, and it has the potential to skip the immunity, which is provided by the natural infections or even by the vaccines. So we are seeing people who are getting reinfected, people who have had infection in the last wave and have received both doses of vaccine about 1 month back. Even our health workers who are they are getting infected again, and it is more transmissible, and it is affecting the younger population now. About the 35 to 40% of the population which are admitted in hospitals consist of younger people, as in contrast to the previous wave, and they are affected more severely. Age pattern is also shifting, and the new phenomena of this wave is that about 25 to 30% of the patient we are having, they are having typical bilateral pneumonia, but their RT-PCR tests are negative. Even after repeat RT-PCR, maybe they are presenting late or ignoring their symptoms. But this is a phenomena, established phenomena, that these patients in the second wave are having more RT-PCR negative presentation. Then there are more thrombotic complication in this wave as compared to last wave, and we are having more cases of sudden cardiac deaths or embolic episodes in this way. So this, I think, now there is one respite that the patient who are vaccinated, who have received both doses of vaccination and completed their vaccination. So if they are being admitted, they are having a milder illness, and majority of them, even some are having severe disease, but the majority of them are having mild to moderate illness and are recovering quite well. And in the current wave, the virus is more virulent, can cause severe disease and death, even in the patient who are healthy, like we have seen in H1N1 epidemic. So the people who are healthy, young, are having severe disease and are dying more in this wave. And the chest involvement, as we go for the CT scan, the chest involvement is very florid in this wave. And the young patient who even asymptomatic having for 50 to 60% involvement in chest CT scan. More number of patients are having chest involvement. And the patient can fast deteriorate. Even in the first week itself, the patient can get extensive chest involvement and oxygen desaturation. And there are more number of ICU admissions and need for ventilators in this way. Briefly, we'll touch upon the state treatment protocol, what we are giving here in Rajasthan. So we have, according to the severity of the epidemic and the limited availability of the resources, the admission criteria are now slightly changed. So this is the classification of the disease: mild, moderate, severe, and critical. Over 80% of the people have mild disease, and 20% have moderate to critical illness. The majority of the patient which we encounter in hospitals are having moderate to severe disease. The moderate disease is characterized by oxygen saturation less than 93% on room air, and with the respiratory tachypnea more than 24 per minute, with the bilateral lung involvement less than 50%. CT severity score is 9 to 15. If it is more than 15, then it is and saturation is less than 90% on room air, with patient having respiratory distress or clinical evidence of acute respiratory distress syndrome, then it is severe COVID. And so the mild disease is treated at home. And for the moderate and severe disease, if there is chest involvement is more, then the patient is evaluated by healthcare worker, and need for admission is now determined. So it is not like the previously that every moderate or severe disease are to be admitted. If only those patients who show evidence of desaturation or ARDS are now being admitted. So these are the revised admission criteria. So patients who are having severe dyspnea, respiratory distress, as evidenced by respiratory more than 30 per minute, or PaO2 or FiO2 ratio less than 300, then it is the patient is admitted, or patient is consistently failing to maintain a constant SpO2 less than, also there is a misprint. So consistently failure to maintain a constant oxygen saturation more than 90, then the patient is to be admitted, or the patient is having a high risk factor like for severe disease like altered mental status because of the poor oxygenation, or signs and symptom of hypoperfusion like hypotension, or patient is in shock, low oliguria, patient having chest pain as a myocardial infarction is an important complication, then suspected or established thromboembolic episode in the patient, or patient is having raised inflammatory markers suggestive of severe cytokine storm. So all these patients are to be admitted. Otherwise, if the patient is showing CT scan involvement of more than 50% even, but he is maintaining oxygen saturation more than 90%, he has to be treated at home. So what do we do in the monitoring in these moderate cases? The monitoring, you all know, is by hemogram, chest X-ray. HRCT scan is now a favored modality because one can quantify the chest involvement. Although a word of caution here, that whenever you see a CT severity score please do not assume that it is the actual. Please correlate it with the actual films. Sometimes it is because it's a subjective thing. Some radiologists tend to uh, estimate the findings. Some tend to underestimate the finding. So
we have got a radiologist right now after
yes, sir. So it has been seen, and I personally know some radiologists who overestimate, some underestimate. So you need to develop a clinical understanding, and with experience, you tend to know how much the chest involvement is there. So always review the films along with the report. Then ECG should be done daily. Blood sugar charting, because COVID itself can lead to development of diabetes or impaired blood sugar. Along with, we are using steroids in this disease, which they also impair the blood sugar control. Renal function and liver function tests are frequently, now in second wave, we see more frequent deterioration of renal function and liver function in previously healthy individuals. And liver functions should be monitored more closely when the patient is on remdesivir, because it is a known side effect of remdesivir. And while the renal function test, when you are administering remdesivir, the certain creatinine clearance should be there. So creatinine clearance should be more than 30, and otherwise you cannot give remdesivir. Then D-dimer, CRP, and IL-6 should be monitored serially to know for the development, progression of disease and development of cytokine storm. The treatment, mainstay of treatment for moderate disease is oxygenation. The target SpO2 is 92%, because now oxygen is very scarce in healthcare settings. We are now opting for the target of 92. So the target saturation is 92%. And in COPD, it is seen that the older people are tolerating hypoxia better than the younger people. And in those people having COPD, the less than 90 or 88 to 90% saturation is okay for them. Then awake prone positioning, we should emphatically encourage the patient to assume prone positioning, and the effect of, or the beneficial effect of prone positioning is evident immediately. As soon as you make the patient prone, within 2 to 3 minutes, you can see that the saturation is increasing at least 3 to 4%. So this is easily demonstrable, and once we demonstrate this, the patient is encouraged and motivated enough to assume prone position. And we should emphasize that the prone position should be carried on for at least 12 to 14 hours in the period of 24 hours. Then the steroids, dexamethasone or methylprednisolone. Some favor methylprednisolone because of the better lung penetration, but the recovery trial was with dexamethasone, so it is a standard, included in standard protocol. 6 milligram per day is a standard dose. It is more effective or most effective on the patients who are on oxygen therapy, and should be discouraged in patients who are not on oxygen, but can be given in a low dose if the patient is having high grade fever and severe fatigue. Then low dose dexamethasone can be given. Anticoagulation should be started in moderate disease to prevent the thromboembolic complication. If we come to the antivirals, the remdesivir, although it is not having a proven efficacy, but it is an antiviral which should be given. This is important, which the remdesivir should be given in the initial viral replicative phase of the disease, which is in the first 7 to 8 days of it. So after 7 to 8 days of the disease have passed from the first symptom, the remdesivir's role is very limited and it may not be beneficial at all. So if the patient is worsening and the patient is in the 11th or 12th day of disease, or 14th day of disease have passed, then remdesivir will not be effective, and it is wasteful to use remdesivir in these patients. Remdesivir is now given as a 200 milligram IP infusion on first day, then 100 milligram per day for next 4 days. Some people now curtailing the short regimen, but they are not scientifically proven. Convalescent plasma is now not much favored, but can be used as a last resort. But it is also only effective within the first 7 days or the replicative phase of the disease, which it can be 200 ml of plasma can be given and can be repeated in some cases.
Well, would you just like to give there was a question. It
Yes,
is
sir.
just that remdesivir, all these other antiviral drugs, Fabiflu and all these things. How about your take on it?
Sir, as Gangakhedkar sir has already told, uh, we have a limited experience of using favipiravir, and the favipiravir, the evidence was not very strong. It was developed in Russia and used in some countries, but the evidence is not very strong. In India also, it is only approved for the mild category of illness. So, if the mild category of illness goes by itself, and using a specific antivirals which are having modest efficacy is not recommended. So, favipiravir is not recommended in any of the
Fine.
international or national guidelines or
All
in
right.
AIMS guidelines. So, in the state protocol also, we are not recommending favipiravir.
Fine. Fine. Thank you.
So,
Thank you very much.
although it is being used in private sector much, but I'm yet to see any beneficial effect of favipiravir, and it has got a serious side effect of hyperuricemia. I've seen patients developing hematuria with uric acid stone while having
And
using favipiravir.
what is your carry home message for for today's this on treatment protocol? Just
So
in two
for
lines.
the carry home message is for to uh, use remdesivir judiciously, and we should not make patient run for remdesivir here and there. It has got limited use within the first 7 days of illness. If the disease is progressing, moderate disease there, patient is having extensive involvement, CRPs are higher. So if we see that the patient is likely to worsen or having more than 9 out of 25 score on CT scan, then we should use remdesivir. But
Fine.
if the patient is presenting later, then remdesivir will not be effective. Then the mainstay will be steroids.
Thank you. Thank you
Yes,
very
sir.
much.
Thank
Thanks
you.
a lot. Now, I'd like to invite Dr. Bharti is here, Dr. Bharti Malhotra. Can Dr. Veena introduce her? Javi, can you put up her slide? Dr. Bharti is here. Dr. Bharti, you have to unmute yourself. And for that purpose, I'll just, now you unmute so that I'll have. Dr. Bharti?
Okay, hello. Good evening,
Yes.
sir.
Very good
Thanks
evening
for the
and welcome.
invitation.
And Dr. Veena will be.
Good evening, Dr.
So very
Good evening, Dr. Mania, and
plan-
good evening to everybody.
good evening.
And I'm happy to introduce Dr. Bharti Malhotra. Welcome, Dr. Bharti Malhotra, to in this webinar. She is a professor and head of microbiology department of SMS Medical College. Dr. Bharti is well-known figure in Rajasthan, and she is very much involved in this second years of Corona to manage the all of the Rajasthan. And she was the former dean and the pro vice chancellor of Rajasthan University. She's very much involved in the basic research, and she's very top academician. I won't take much time. Dr. Bharti, please deliver your talk.
Thank you, ma'am. Thank you for the invitation, sir. It's been a long association with you. I will now share my screen.
Yeah,
Sure.
Dr. Bharti.
Can you see my screen?
Yes,
Yeah.
yes.
Yeah.
Okay.
A brief presentation, your testing strategies and what message you want to give in 5 to 7 minutes. So that
I will be very fast. The slides are more, but then I'll be very quick with it because everybody is well
waiting.
aware of the testing strategies. So I'll just be going through the testing strategies very quickly. I don't really need to. So we all know we have various diagnostic modalities. One is most important is the molecular test, which are the gold standard. Then is we hearing a lot about antigen tests. So diagnosis is can be done by antigen test, but if they are negative, they have to be confirmed by the PCR tests. Antibody-based tests are not used for diagnosis. They are used for serosurveillance and plasma therapy and monitoring the response to vaccine. As a traditional method, culture can be used, but culture is not used for diagnosis, only used for research work. So in a molecular test, we have the real-time PCR. There are many point-of-care tests. Then there is a new FELUDA test. And then you will hear a lot of things about using the dry swab in limited resource settings. And of course, the sequencing is used for molecular epidemiology. So I'm not going into the basics of real-time PCR. For any real-time PCR test or any test, we have to do a proper sample collection, the nasopharyngeal and throat swab. If you do both, the sensitivity increases. And we have various steps in the lab. As a result, it takes, depending on what method we are using, it takes 15 minutes in case of very rapid point of care methods, and it may take up to 20 hours depending on the load of the lab and when the sample reaches the lab. So we have various steps to do: the lysis in the BSL2, the RNA extraction, then amplification and detection. So all this takes about on an average 8 hours in our lab. So multiple kits are available. Initially, there were two-step kits. Now we have multiplex PCR kits, and basically we have to look for the E gene, which is the genus specific, and then we have to look for the specific genes, the N or the S gene, and then or the ORF and the RDRP, which are the confirmatory genes, and then confirm it to be a real-time PCR positive. We do the entry and through the ICMR portal and through the app, you can then get the results can be available on the patient mobile. So these are the various platforms. We have this fully automated system of the Roche, which can test up to 4,000 samples a day. Of course, it is more expensive, so it has its own limitations. Then there are other platforms like halogenic hologic panther, which is again can test up to more than 1,000 tests in 24 hours, and results, it is fully automated, easy to perform. Then there are point of care methods, even in a remote setting. We have these gene experts and TrueNAT from the TB control programs, which can be also be used for the SARS-CoV-2 testing. And we are using it extensively in our lab. The gene expert for urgent samples like some patient with cardiac arrest or with perforation, or even very quickly we want in some case of dead bodies, then we are able to give results within 45 minutes. But it is expensive, so we don't use it as a routine. And TrueNAT can also be used, and it is available in a lot of CHCs and PHCs. But the kit availability of the kits and the cost is an issue. There are many n number of kits which have various genes, and we report them accordingly, and they can be used on different kinds of platforms. So ICMR has issued testing strategies from time to time. So they have advised use of real-time PCR, the TrueNAT, the CBNAT, and they've also advised use of point-of-care antigen testing. But antigen testing, they have moderate sensitivity, but they have high specificity. So if they are negative, you have to confirm for by the real-time PCR. So the ICMR has also issued guidelines for how to set up a PCR lab, what all is required, and how to go about getting the accreditation from ICMR. And for private labs, NABL accreditation is a must to get going before the ICMR. So then there is a new FELUDA test you must have heard, which is actually an acronym for the FN Cas9 Editor Limited Uniform Detection. It has been based on this acronym has been created by Bengali writer Satyajit Ray. So it's based on that. The acronym, it can give result within less than an hour. It is faster than the gold standard RT-PCR, and it was created by Genomics of Integrated Biology (CSIR), and it is being launched by the Tata Group. So it has 96% sensitivity, 98% specificity, and it is based on the CRISPR technology, and it is approved by DCGI. All kits have to be approved by DCGI or the ICMR, so before using them in routine. So this CRISPR-based technology is actually the CRISPR stands for Clustered Regularly Interspaced Short Palindrome. So which is a very good technology evolved by the our country, and we are quite proud of it. And then you must have heard a lot about the mutations, the various mutants which are playing havoc in the current second wave. So how do we identify these mutants is only by the genomic surveillance. So we need to identify the prevalent strain. So it helps in molecular epidemiology. We can look at the transmission dynamics. And
Bharti, there was a question. Are we doing it here in our country or here in our state, all these genomic studies?
In our state, we have the infrastructure. We have asked for the funds for the same, but currently we're sending the samples to, earlier we were sending samples to NIV Pune, but now INSACOG is a national consortium which has been made, and according to that, we are sending our samples to IGIV Delhi. So we have written to government to give us the funds to carry on, and we can do it here,
But
but we need funds for that.
some studies are going over here in our country also.
Of course, yes, yes. This INSA, I'll be telling you about INSACOG. Like these are a lot of publications are there from India, which they have done it on their own various centers. This is full genome sequences of the first two COVID-2 sequences was from NIV Pune. Then there was another study by Arindam Matra and group. And these again, you will find this is from the Sophia Banu. This is all these studies were coming up. And then when in December, we noted that from UK, the B1.1.7 lineage was reported, and which was having high transmissibility, and suddenly the second wave in UK was more, the transmission rate was very high. Then this INSACOG was formed by Government of India. It is the INSACOG is Indian SARS-CoV-2 Genomic Consortium, which is 10 national labs. They are jointly doing the genome sequencing, and they are doing the whole genome sequencing to look at the various variants in the Indian patients. So these are the 10 centers, and the idea was to the all international travelers, they were to be tested, and then from the community they were taking 5% samples from each lab, all 5% positives, and then they were doing the sentinel, doing the surveillance. So now also to looking at any high positivity areas, so those are also being tested. So as a routine, every week samples are being sent to this consortium by the whole of the country, and they are doing this testing. But now looking at the second wave, they have changed the strategy to 10 surveillance sites per state, and they will be doing 150 samples in 15 days. So 300 samples per month they will now be testing. So initially it was 5% when the numbers were low, but now with the increased positivity, they have changed the strategy as per WHO, and the idea is to look at the disease epidemiology and each state and most of the districts. So that is the purpose. So what they found out was that various strains were prevalent, like in Punjab. They found a lot of UK variants were present. In Maharashtra, B1.617 variant was seen. In Delhi, again B1.617 UK variant was seen. So even otherwise, they have seen this is just a picture of what all mutants are prevalent in different areas of the world. So if you look at the number one, these are the mutants prevalent in the cluster 5 mutants were prevalent. The UK variant of concern, which is the B.1.1.7. So that has the N501 mutation. And then the South African variant has 3 mutations, which are common, and various deletions are seen. And of course, in our strain in Rajasthan, what we got is that UK strain is we have found about 33 samples of UK strain. Other strain we haven't found in our Rajasthan samples, but with this INSACOG, we have been sending them samples, and that's what the report says. And we have also finding that 3 mutant strains are now prevalent in Maharashtra and in Bengal. So these are if you look at the number 7 here, these are the 3 mutants, 452R, E484Q, and the P681R. So these are the triple mutants which are prevalent nowadays in India and which are cause for concern. So a lot more systematic sequencing is required, and to know what variants are prevalent in various parts of the country. And you must have heard some news about Andhra Pradesh is having now N440K mutant, which is again has all these important things about these mutants are that many of them are escaping, have the immune escape phenomena. That is, they are not getting like they are escaping the vaccination, and then this is the cause for concern. So now ICMR has asked us to send samples from people who have got vaccinated and still they have become positive again. So to look at the breakthrough mutants. So all this is going on at a high pace in the country, and various data are emerging. On what are the prevalent mutants in the different parts of the country. So then another thing is the antigen test. Somehow we are not using much in our state, of course, because that is the reason is that we have a very good infrastructure lab network of the real-time PCR labs, and each and every district in our state has a real-time PCR lab and the state of the art. So, and they are testing like our capacity is to test 10,000 samples, and similarly other different labs have different capacity, and they are testing from 2,000 to 7,000 samples a day, and that is why. But now looking at the surge in the number of tests, our state is also looking at starting the antigen test. The important thing of this, it is a point of care test. You can do it from the nasopharyngeal swab, and the sensitivity has to be more than 50%. If it is on the direct on-site test, like there are two kinds of antigen tests. One is you can do it from the VTM, which we are getting for the PCR test, and the other is that you have to do it on site, and there was a special buffer provided in the kit, and you have to collect the sample in that and do it on the bedside. Within 15 minutes, you can look at get the results, and you can triage the patients, and symptomatics, if they are negative, they can be confirmed by real time, and the others, if they are not symptomatic, you can consider them as negative and proceed with the whatever needs to be done. So these are the directions from ICMR for the rapid antigen testing use. And again, ICMR has issued the new guidelines yesterday, which I'll be coming to later on. But the thing is that various kinds of antigen tests are available, and we have also been part of validating these antigen tests. And so there's many companies which have come up with these antigen. So then there are another kind of antigen test which require a machine. You can look at the fluorescence. So they are rapid, but they need a small equipment which needs to be there, and the sensitivity should be higher for those. And then you can also do it from VTM. Again, the sensitivity should be higher for those. Then the antibody testing, we know it has no role in diagnosis.
But one question,
Earlier when plasma,
Bharti,
convalescent plasma was being given.
can I interrupt you here? One question is there,
Andy.
that people, even after doing the vaccination, and they do not
Hmm.
show the antibodies. What is your take on that? And number two, those people, those who are symptomatic but still not showing any this RT-PCR positivity. These are the two most common questions which are coming in the eye. So you just finish your presentation with these two questions.
I'll take one by one. Number one is the many symptomatics are not showing PCR positivity, because PCR positivity is supposed to be 70%
Right.
sensitive only, and depends on what sample you're taking. If you're taking both nasal as well as throat swab, the sensitivity increases. The ideal sensitivity would be they say is taking a bowel sample, but that's not very practical and aerosol generating. So one has to also look at the symptoms, and as Dr. Abhishek and Dr. Gangakhedkar told us, that you also look at the HRCT, and then you look at the symptoms, and then you decide. And even now, ICMR has issued a guideline: if patients are anybody is symptomatic with these particular symptoms, even without a test, you consider him to be a COVID positive patient, unless any other etiology is proven. So you have to, with the very high positivity rate going on in the second wave, more than 20% positivity as per the data available from ICMR in the country. So you presume the patient who is symptomatic to be positive, and then treat him accordingly and isolate it till he is proven otherwise. So that is the take on the PCR test. And many times we have seen, when we have been following up the patient, sometimes the viral shedding is intermittent. So the same patient may be negative today and positive tomorrow, and was positive yesterday also. So that also we have seen when we were following up them on a regular basis in the initial phase. Of course, we are not doing that anymore. So that is another aspect with the PCR. And then another thing is, when you are collecting the sample, when it is reaching the lab, and various kinds of delays can be there, and how it is being transported when it is being tested. So that can also affect the sensitivity of the PCR. And there can be some inhibitors also. So you need to have those kits which can give the internal control, and they can tell that the sample has been collected and transported properly. So there are many issues in those regarding the PCR. And number two, for the antibody testing, yes, you will find that many people have been vaccinated, still you will not find an adequate immune response. So there are two aspects to that. Many kits have just evolved. How good are those kits? That needs to be seen. There are many kits. There some are CLIA based platforms, others are ELISA based platforms, and some are detecting total antibody, others are detecting neutralizing antibody. So a lot of evolution is happening in these antibody kits also. So in our department also we were doing the study, and then we were finding a very varying response. And even when you have an adequate antibody response, so to say, even then people are getting positive in the second wave. But of course the disease is milder. So that is what the take home message is, that the vaccination, even if you are getting reinfected, the reinfection, the disease profile is milder. And because some of the mutants are also escape mutants, so there are many things which are playing into causing the immune response. Maybe the mutants may escape the immune response and cause the infection, or no vaccine is 100% sensitive, even effective. Even all these vaccines are supposed to be 70 to 80% effective. And a lot of things are also going on. Do we need a third dose? So all those things will tell with period of time when we do evaluate these, what is happening. So basically we need to look at these factors, what kit we are using, what platform we are using, and whether we are looking at neutralizing antibodies, we are looking at total antibodies. So all that will affect our interpretation of the role of antibodies. Then these are the various kits which have been validated by ICMR. Of course, we are not using for diagnostics. We are using it for the virus culture. Again, there's no use in diagnosis. You use it for research purpose, and you look for efficacy of vaccine. So you must be reading a lot that NIV has evaluated their vaccine against various variants. So the NIV has successfully grown the UK variant, the Brazilian, and the South African variant, and checked the efficacy of the Covaxin against these variants, and then found them to be quite useful. So this is another publication from NIV where they have done the culture, and they could successfully culture the virus and look for the vaccine response.
Well,
So each method has its own utility, but we have to look at what we want out of that method and where we want to use it. So the new guideline from ICMR says we do not need to repeat the test if the person is positive. There is no need for repeating the test when person is being discharged. And then there is no need for doing the PCR test when interstate domestic travel is being done. And all non-essential travel should be avoided. Even they have set up mobile testing labs which are available on the GEM portal. You can use those systems and do the testing. Testing booths can be established in various community centers, the offices and schools and colleges, where you can do either the PCR method or the rapid antigen method. And one thing I would like to comment on the rapid antigen method is when the positivity was low. So then because these antigen tests we have been validating, and it should have more than 50% sensitivity. Now the positive predictive value of these antigen tests has gone up because the overall positivity in the population has gone up. So these antigen tests would be quite useful, and even our government is debating on using them. So we very soon that might also start in our setting. And each test has its own advantage. These tests can be used in the peripheral setting, like at the railway station, the schools, and the bus stands, if government still wants to do that, though ICMR is not recommending it anymore. And so these are the various changes which are happening on a live basis. And that is all I wish to share with you.
thank you.
Thank
Thank
you.
you very much.
Thank you, sir. Thank you for the invitation.
Thank you very
And
much.
thank
It
you.
was nice to hear. And now I would like to invite uh, Dr. Shitu is here. Dr. Shitu,
Doctor, Am I audible?
Yes. But let me see, Dr. Shitu, can you respond? She was here, I could see her. Dr. Shitu. Is Dr. Prerna Singh?
Yes, sir.
Is Dr. Shitu here?
No, sir, Prerna.
Right. So, please, a brief introduction of Dr. Prerna, and then she will. Prerna, just take 5 minutes to give tips of HRCT, what people should,
Yes.
what not to.
Yes, sir.
Yeah. Welcome, Dr. Prerna Singh. She is the consultant in the radiology department of Rajasthan Hospital. She is young, dynamic, and she's going to speak on the. Dr. Mathur is already there, and she is the consultant radiologist in SMS, Sony CT MRI previously, and consultant radiologist in Moscow. And she has more publication, and now she's working in Rajasthan Hospital, Jaipur, and she's now very busy in this COVID era. Dr. Prerna, please share
Briefly
your
within
screen.
5 minutes, Prerna.
Dr. Prerna, please share your screen.
Yes. Is the screen visible?
Yes, visible.
Okay.
Just try to keep up time because we have to finish up within 20 minutes.
Yes, sir.
There are lot many questions.
Yes, sir. So I'll start. Good evening, everyone. I'm Prerna, and I'll start. Thank you, Dinesh sir, Veena ma'am, for such a nice introduction. So today I'll be just briefing about uses and indication of CT in COVID pneumonia. The topics I'll be covering today will be very short. It will be on typical findings of CT chest, the severity score which we day to day see in our reporting system, the CORAD system which we follow to give about the imaging details and correlating them clinically for the case of COVID, the indications for CT, about long-term follow-ups and how do we have to follow up with CT, and radiation doses, which is very important in this era when the COVID is being correlated directly with CT. Many just on the basis of the findings and take-home message. My first thing is when we deal with a patient of corona, the pathological sequences which take place in the body are visible on images. The early stage, when the first 4 days of the symptom, we only see ground glass opacities, the crazy paving pattern and involvement of the interstitium, which is a typical feature of atypical pneumonias. With the progressive stage, we can see 5 to 8 days, we see there's extension of ground glass opacities and crazy paving patterns. Peak stage is consolidation, which takes place on 10 to 13 days. And in resorption phase, we see the gradual resolution. So the progressive and the peak stages are the increases the sensitivity of CT. And that is why the indication for going for CT is in the second week of the symptoms. So along with the CT changes, we can appreciate, this is the CT which was taken in the early stage. We can appreciate these ground glass opacities, scattered ground glass opacities within them. With time, they become well-defined patches which can be appreciated as consolidation patch with surrounding ground glass opacities. These are the mixed patterns. These are the crazy paving patterns which are described as whiteness, the septal thickening, interspread areas of ground glass opacities. And these are the consolidation patches. Moving on to more severe disease, there is consolidation of bilateral lower lobe involvements. And then these are the resolution bands where we can see these bands and the surrounding residual ground glass opacities. Moreover, absorptive phase. Now, taking these findings, we divide the lungs in 3 parts. The right lung is divided into upper lobe, middle lobe, and lower lobe, and left is divided upper and lower. So we give them scoring from 1 to 5. 0 is no involvement of any of these lobes. 5, then with every 25% of the lung involvement, we go to most severe one, that is 5. Total score is given out of 25, and then we get the final score out of 25, which is described as CT severity score, CTSS. If it is less than 8, it is a severity of mild, 9 to 15 is moderate, and more than 15 is severe. So now, after implementing the CT severity score, we give a CORAD, that is the radiological and data system. In that, we give a scoring, a numbering to the findings, which decide whether these are typical of COVID pneumonia or not. Starting with 1, it's no, there are no abnormalities found on the HRCT chest. In 2, low probability, because other findings, supportive findings like central lobular nodules or any cavitations, which are not typical of COVID pneumonia, and we need to think of some other etiologies like tuberculosis or a cavitatory pneumonias. When we have indeterminate, that is number 3, we are not very clear. We are finding effusions, we are finding subseptal GGOs, or we are finding lymphadenopathy, which are not typical of any COVID pneumonia findings. When the high suspicion is when we have unilateral findings, or we are finding ground glass opacities which are less scattered or are showing a predilection towards a single lobe. Then very high are typical features of the peripheral ground glass opacities with areas of septal thickening. And cohort 6 are the already proven cases. Now, when to get a CT done? The preferred time to get a CT is within the 2 weeks, because in the second week, the inflammation is at its most and the picking up of the findings is more probable. We can get false negative imaging. What is false negative is that a patient is COVID positive, but it came to you particularly in the first 2 days of the symptoms. In the first 2 days of onset symptoms, we can get, there will be no imaging details, but later on the patient may develop a COVID pneumonia findings. Indications: chest imaging is not indicated as a part of screening for any asymptomatic patient who came in contact with a person or for mild respiratory symptoms. Triage of patients: when we have a patient in emergency which may require an urgent procedure like an hemodialysis or any cardiac procedure, neurological, then we can go for a CT scan to triage it, and our findings may differ, alter its further treatment, in which, or there may be settings when RT-PCR negative, but we have a strong suspicion of COVID pneumonia, or when the RT-PCR test is delayed, and that may hamper the patient's later on treatment protocols. Chest imaging is indicated in patients with moderate to severe respiratory diseases. Now, how to do it is, you should always follow a protocol of low dose CT chest, because it's a radiation imaging. Any radiation imaging should be always explained to the patient for the benefit over the risk, because any radiation over the is a risk to the patient. And in the second wave, we are seeing most of the people affected are the young or the middle aged. So their radiation dose should always be monitored. And chest radiographs will always be preferred for follow-up in regular ward admissions to see any patches resolving or the management of pneumothorax. Daily chest radiographs in the stable patients are not necessary and may increase the risk for viral transmission to healthcare workers. When we are suspecting a complication or are matching findings to pathological to rule out any thromboembolism, we can go for contrast scans. For hospitalized patient with COVID-19, if a symptoms have resolved, the CT chest is not required to give it a criteria to discharge the patient. So we can obviously go with clinical and laboratory findings, and decision regarding discharge is not based upon CT. Follow-up scan can be based upon the clinical findings and underlying comorbid conditions. Not much follow-up studies are available. This study in the thoracic imaging research gave a 6-month follow-up chest CT, and there were fibrotic-like changes seen in more than 1/3 of the patients who survived. But the criteria for these patients were that they were in older age, they had an ARDS, they had a longer hospital stay that was more than 17 days, they had a tachycardia more than 100, non-invasive mechanical ventilation, or they had a high initial CT score of 18. So these were the comorbid patients who developed the fibrotic change. Otherwise, the many patients showed resolution. Radiation hazard. A chest X-ray gives you a radiation of 0.02 millisieverts, that is equal to 2.4 days of the background radiation. So a CT chest gives you 3 millisieverts. Like having a CT chest is equal to 150 chest X-rays. And you can just do your maths and how long you've taken for the days of background radiation. So framing CT as a pivotal role for COVID-19 diagnosis is a distraction during a pandemic and possibly dangerous, because we are using them in young and middle-aged people, also in mild asymptomatic patients. Even with proper cleaning protocols, the healthcare professionals and CT scanners would become vectors of infection, and they would get infected. And even the patient, other vulnerable patients who require imaging, because CT is a closed scenario where there's no ventilation, we don't have anything which could change the air. So the high infective ratio increases along the CT because of the misuse of the CT. So the take-home message for me will be, CT can play a role for triage a patient to decide whether the patient should have to go for ICU, for home isolation, or for admission. It can predict your worsening or any treatment protocols if they are failing, or you are suspecting any problem solver for your treatment. However, it is not the standard of diagnosis, and it only helps you to suggest for an appropriate treatment. Severity should not be correlated with clinical findings. It is crucial to correlate your chest findings with the epidemiological history, clinical presentation, and RT-PCR, which will always remain the gold standard for your diagnosis. Thank you.
Thank you very much, Prerna. Thanks a lot. There's just one question I would like to ask you, whether the clinical management is more important or the HRCT. Those who are
So
negative.
definitely, clinical management is more important because at the end of the day, how a patient feels is much more important than what is seen on the CT. Slowly resolution occurs. There are many people who are discharged at a severe score and they do well later. So HRCT score is not related to your findings. They are just a helpful diagnostic treatment which can be used for old morbid patients to follow up for their fibrotic changes.
Dr. Prerna, sometimes the patient are very much in anxious if there is any changes in the CT or the HRCT.
Yes, sir.
And they are absolutely normal, but they are very much keen and why this is occurring. Is there any long-term?
Yes, ma'am. That is right, because this era is really facing a lot of problems with getting many mild cases done for CT. They get a score of 2 or 3 and they're very conscious for that. They get it again, but they don't understand the hazard of radiation they are facing.
So one of my family members, she is having the only fever. She doesn't have any respiratory problem. She doesn't have anything, and she is having 900. Do you recommend her CT?
No, ma'am. I don't recommend a CT unless it is a moderate or a severe disease, because CT unnecessarily creates a fear in the patient. They start taking medications not required, and that is really harmful. And if the young and middle-aged population which is getting affected in this COVID rate, they really need to be cautious for their CT.
If there is no problem.
Thank you very much. Is Dr. Ravindra Rao here?
Wonderful.
Thank you.
Dr. Ravindra Rao, because I thought that we will talk of respiratory system. We will talk of different systems, cardiology, respiratory, and this pulmonology, psychiatry, skin, and the holistic approach. So is Dr. Ravindra Rao here? Dr. Ravindra?
Sir, please, should I start? I'm waiting. Hello?
Dr. Ravindra?
No, sir, I'm Dr. Pankaj.
Dr. Pankaj is going to start.
All right. Let me see. Is Dr. Pankaj here? Hey,
I'm here, sir.
Sorry, I know. I called Dr. Ravindra. If I don't listen him, Dr. Ravindra. Is Dr. Ravindra here, or and Dr. Raghav? Is Dr. Raghav Shah here? Dr. Pankaj, and I can see Dr. Pankaj, you will be a holistic approach, and after that, our dermatologist, Dr. Gulati, will tell everything about the skin. All right, Pankaj, please.
Okay, just a minute, sir.
There are so many questions in the chat box. Now you can ask.
Just a minute. Pankaj, is there any?
Yes, sir. I'm available now.
Yes, please keep your presentation brief.
Yes, sir. I don't have any presentation. I'm just speaking on the topic.
All right.
Good evening, everyone. I'm Dr. Pankaj. I'm a consultant physician. I'm looking after the COVID patient in Rajasthan Hospital, in ICU, in IPD, and I'm providing online home care package all over India to the corona patients. And I'm seeing there are a lot of chaos going there all over India because there are no beds available and people are helpless actually. So it requires more holistic approach to treat those kind of patients. So as we know, we have limited resources in terms of allopathy. Right now, even drugs and oxygen is not available. So we are combining more alternative approaches in our medicine, in our treatment of the COVID. And in first wave also, we have seen very good response by combination of different kind of pathies in the COVID patients. And in second wave also, since the symptoms are severe, infectivity rate is very much high, the spread is much faster and complications are much more. So I would say this time in second wave, this is be more applicable to do holistic care of the corona patients, because sometimes in at least 10% or 20% cases, patients are not responding well enough to the all kind of allopathy medicine whatever we have having, including tocilizumab or remdesivir or whatever high-grade antibiotics we are able to provide the patient, but still patient not responding. So in terms of different kind of pathies, I would say that first 5 days are very, very critical. So if you start medicine as soon as possible, because this is my, again, my anger point, people are coming still to us on day 6 or day 7. So when the viremia part is over and the complication phase started already there, so we can't do much for them. So since the immune abrupt behavior is there in the COVID, so we don't know which patient will progress faster or which patient will having the normal course. It's difficult to predict seriously. So whatever we can give on day 7 or day 8, it's usually not that much effective. So I would say the first take home message, we should start treatment on day 1 as soon as possible. Please don't wait for the COVID report. Please don't wait for the CT scan. Please don't wait for blood test. Just start taking treatment under guidance of your doctor, and keep yourself in isolation to prevent yourself and your family and loved ones from getting exposed to this deadly virus. Now, considering the holistic part, I would say in last wave also we have seen I provide the diet part is very, very important, because since this time also the gut symptoms are very, very common. People are presenting with severe diarrhea, severe vomiting, severe pain abdomen in first 2 days, and even in second week also people are having diarrhea and vomiting and gut symptoms. What I have seen, if somebody is coming with a gut symptom, it's usually not resolving with any kind of therapy. It is usually lasting till the COVID time lasts, that is 14 days. So it's better to start patient on specific diet that I am preferring right now is basically the light diet, what we use in autophagy or what we use in naturopathy diet. That is simple diet, as simple as that we can give. Because if it is in controversial, it is in contradiction what we usually say, okay, we should provide high protein diet, heavy diet to the patient because patient is weak, but that's not good. Reason being, since our intestine is very, very leaky and very, very weak during the corona time. So if we provide heavy meal, it won't be able to digest those kind of proteins. So better to take any simpler protein. I'm advising to take patient dal water. Simple dal water is the best thing, because it will hydrate you, it will give you salt, it will give the protein part also in already digested form. So the best thing for the COVID corona patient is to give them dal water, especially if they are having fever. Because in the fever, the naturopathy says what we say lung numb is very, very effective. Fasting or liquid diet is very, very, very effective, because all the energy, all the is utilized in fighting against the virus, not using most of the energy that we are having in the body to digest the heavy food that we are taking. So it's better to stop all milk products. It's better to stop heavy wheat products, cooked food. I'm not advising them, and we are seeing very, very good results because fever is responding very well. If patient is following the liquid diet or the simpler dal, water and khichdi diet that we say, and along with that, we are advising patients to take to keep themselves hydrated. That is very, very essential, because most of the patients which are coming to us in the late part are very, very dehydrated. If we do their AVG, the lactate is very, very high, and it is most commonly due to hydration, because this is not a sepsis part. Normally viral disease don't cause increase in lactate. So when we give them lots of fluids, they usually become better. The weakness dissolves gradually. So I would advise everybody to take at least 3 to 4 liters of water, whatever form they should take. Now, as we allopathic medicine part is already discussed, we are using whatever resources we are available without any actual evidence, but we are using doxycycline, we are using azithromycin, we are using ivermectin. I would say we should use high dose vitamin C also, because we are using in inpatient 10 grams of vitamin C per day, and which is giving us some good result. And regarding steroids, we are using them judiciously, and it's definitely having great impact on the patient outcome if we use them after day 6 or day 7. Because in the initial first 7 days, viremia is high. So if we use steroid in that part, it may increase the viral load, and it may increase the COVID duration. So, but if the patient is having on day 6 or day 7 having lung symptoms or severe cough, then it's better to add steroid in the treatment, and it is really having good impact on the patient outcome and the patient symptoms also. So, in the second week we are using steroids, and it is having good impact on the patient response. Regarding the remdesivir part and tocilizumab, it's already been discussed. We are not going in detail of that. Regarding the other medicine, frankly speaking, if you are not responding to the conventional therapy, or like if your fever is not responding, if your cough is not responding, then we have some very good drugs in homeopathy. But don't take them like allopathy, because there is no specific drug. The homeopathy concept is work very, very differently than allopathy. There is no standard medicine for a standard symptom. There is no standard medicine for standard diagnosis. So it is very, very personalized. We should ask the patient symptom. It should be under guidance of a specific qualified homeopathic doctor. If patient come to us, we advise them to connect to our connected homeopathy doctors in our hospital, and so they talk to them and they advise them medicine, and we have seen really good result in homeopathy. Those who are not responding with the allopathy part, so like fever is not responding, not coming down despite taking paracetamol or anti-inflammatory. It is coming on day 6 or day 7 or day 8, because it is clearly indicated if somebody is having fever more than 5 days, then it gonna have more severe COVID illness. So it's better if we suppress fever by using some other alternative ways. Similarly, recent research from the Bangalore, the IGIB team of Delhi is also working in Bangalore, one doctors of us. They founded some specific Ayurveda drugs like Kal Meg they are using. It's having almost equivalent to remdesivir in having 99% effectiveness against the coronavirus. Similarly, the ashwagandha and the mulethi, that the Yashti Madhu that we say, that was also effective in SARS-1, that was in 2003. It is also found almost 93% efficacy against the coronavirus, both of the ashwagandha and the this one, Yashti Madhu, or what we call in simple term, mulethi. So we advise the patients to take mulethi water. It is very, very soothing for the cough symptom. It is very, very soothing for the continuous irritation in your throat, and the weakness part, that is the normally patient of COVID having extreme weakness. So if we give them ashwagandha, it is also acting as antiviral. It is also acting as adaptogen and immunomodulator, and again giving some strength to the patient. So if we start them early, the recovery is faster and the weakness is lesser. So if we apply a different kind of therapy judiciously, I would say the most important part is definitely medicines, because they are actually the crux in also my treatment. But the diet part is very essential, because if you are consuming heavy diet, then it may harm you, because according to the Ayurveda, anything which is increase the cough part, according to the Ayurveda, Vat, Pitta, Kaph, if we know, the cough part, if it is increased in the body, then the corona illness will be severe, because it is creating more cough and more lung symptom in your body. So if you give anti-kapha diet by applying some medicines and by using the specific diet, it is it is helping lots of patients to resolve, to improve on faster way. I think this is my cut. So holistic approach to the COVID, especially in this scenario in second wave, is much more important, because most of the patient are getting more severe disease, having more complications. But you don't apply any kind of therapy that is available in the market directly. Ask your doctor, concern your specific Ayurveda doctor, ask your homeopathy doctor, and use them by only under the guidance of any doctor. Please don't take them directly, because it will not help you. It may harm you if you are taking in wrong way, if you are taking in wrong time, and if you are taking in wrong doses. So please consult your doctor for better response, and please please focus on the diet part because that is extremely important. And one more advice I should say, don't use Nariyal Pani in COVID because people are using a lot for hydration. Again, it is cold in nature according to Ayurveda and increase the cough. So it may increase the progression, it may increase the risk of pneumonia in COVID patients. So better to use electrolyte powder or ORS water in COVID patients. Thank you.
Thank you very much, Dr. Pankaj. Pankaj is a MD medicine from All India Institute of Medical Sciences. I know him. He was working with me in C.K. Birla Hospital earlier also. And Pankaj has served government of Rajasthan as an assistant professor of medicine. But nowadays he is almost converted into Ayurveda as well as homeopathic. He has got a very holistic. So I thought that he will be the most right person to give the holistic approach. Thank you very much, Pankaj. Thanks a lot. And now
Thank you, sir. Thank you for
I've got Dr. Gulati, who will tell you how to take up your skin and what are the skin any specific skin manifestation, or how to beautify your skin during the COVID era. Dr. Ram Gulati is a senior consultant in Santokh Badurlabji Hospital here in Jaipur, and he has been all from SMS Medical College. He was in England for several years, worked in the NHS, and now I present you Dr. Ram Gulati for the dermatological aspect. Dr. Ram.
Thank you very much, sir. I'll just share the slides.
Please.
So I think you put that title there, Tan Ki Baat.
Yes.
That was wonderful.
I kept दिल की बात, I kept मन की बात. वो दिल की बात करने वाला कोई किसी का दिल टटोलने चले गए और मन वाले मन टटोल.
मन की बात तो बहुत सालों से चली रही है सर.
Right.
Right. Looking at the Tan Ki Baat, so more of the skin. So just allotted 5 minutes. I'll just take you very quickly. Just a moment. Right. So there are only a few things I think from the skin perspective that we are worried. One of them is what are the skin symptoms and signs we see in COVID? So is there anything which is pathognomonic? Can infection transmit through skin contact? And there's a lot of buts and ifs about the fomite transmission and use of sanitation. And then the personal protection and skin changes. What does personal protection comes with its pros and cons? So as far as skin involvement in COVID-19 is concerned, the studies are quite variable.
Just tell about the fomite transmission. You have touched that issue. So please be in detail with the fomite transmission.
Yeah, I'll pick that up, sir.
Right.
So from the skin involvement, I think that there are studies which show that only about 0.2% of the COVID-19 patients had skin involvement, but then there are studies which show that almost 20% had them. So there's quite a number of variability. But most of the rashes that you see in COVID-19, they occur on the trunk and limbs. Now, there are a lot of reports from the Caucasian population, so more in the Western side, and we have got relatively less number of publications from our side. So maybe these are the rashes which are seen more commonly there. They usually 70% of them are going to present some itching, burning, and very rare pain. And these rashes can either precede, they can occur either during the infection, or they can simply follow the illness. Now, just picked up from one of the beautiful articles from Snoopy's. So they have just described the 6 presentations that they have seen among the different studies that they took into consideration. So one of the most common is urticaria or wheals. So there's nothing specific about urticaria. When we know that one of the most common causes of acute urticaria is viral infection, and COVID-19 is no exception. But then you can see morbilliform or maculopapular rash. Again, it is a blanching erythematous rash, mainly on the trunk and the limbs. And again, it's going to be self-limiting. Then even papulovesicular lesions are found. And then there's always a confusion with chickenpox. COVID toes has been touched many times. I think initially when the pandemic hit Italy for the first time, we had a number of publications from there regarding COVID toes. And eventually it came as just a manifestation of the thromboembolic phenomenon. And many of the subsequent studies have in fact shown that many of those patients did not have COVID as well. So it is a big question mark. And then there are studies which have shown presence of livedo reticularis-like lesions and then vasculitic lesions as well. So if you look at the various studies, the most common is the maculopapular or the urticaria rashes, which are self-limiting. And even if you don't do anything about them, they're going to just go away in a week or two. Then you can have these chickenpox-like rashes, or you can sometimes have chilblain-like acral lesions. Again, they tend to resolve on their own within about a couple of weeks, but then there's always a confusion with chickenpox. And I think if there is a confusion, then one should just treat the chickenpox part as well. Or you can do a Zank smear and see if you can differentiate. Livedo reticularis and vasculitis is rare. And these two definitely need a dermatology intervention and need further investigations. And you have to look at whether it is COVID-19 induced or it is a drug-induced vasculitis or drug-induced livedo. And those will probably need systemic steroids. For most of them, wait and watch, itching, you give H1 antihistamines, or sometimes you can need a low-dose steroid, but mostly they are self-limiting. But apart from these, a number of other rashes are seen as well. For example, erythema multiforme-like rash, Kawasaki-like rash. And one of the very common things that we are seeing in clinic is hair loss following COVID-19. And that is the post-infectious effluvium, which you also see in other infections as well. But the good thing is it is usually all recoverable and it comes back. When you have got these petechial rashes, then definitely you may go down the line of DIC or low platelets. And that can be one of the reasons that the people get petechial rash in COVID-19. So if you see all these rashes, there is no specific skin rash for COVID-19. So you can't diagnose COVID-19 on a particular rash. But if that rash is associated with some history or symptoms which are suggestive of COVID-19, then you do think as an association of that, but always put differential in your minds. For example, chickenpox, for example, drug rash, which is one of the most important differentials when you consider COVID-19. Apart from the rashes that you see in COVID-19, one thing is very clear, that skin as such, for all practical purposes, is not a portal of entry for COVID, because that needs ACE2 inhibitors and is largely respiratory and other mucous membranes, especially eye or mouth. So it is not a portal of entry, but again, it can be a facilitator of transmission, and there where the fomites issue comes in. Now, a lot of people, they are obsessed with sanitation. So how is the fomite transmission going to happen? For example, if you have got surfaces in the outside world, for example, door handles or railings in the public area, and we think that the droplets might have actually settled on these, and then you touch these areas, and then you need to touch your eyes or mouth or nose for that virus to actually go into the mucous membrane, only then you get an infection. So if you avoid touching your hands to your face, that is the best thing you can do. And therefore, use of masks and use of face shield is very helpful, so that you don't touch your hands onto the face. Again, gloves are going to come handy with that. So I would say that yes, you need a sanitizer when you go out, but there are people you see in the clinic who come and they are sanitizing their hands every 15 minutes when sitting inside the house, which is not of much use because you're not touching anything which is infected. When you use excessive sanitizer or the hand washes, then you tend to get dry hands. So we need to actually put a lot of hand moisturizers during these times to make sure that the skin epithelium or the skin surface remains good and intact and healthy. And with the use of these alcohol-based sanitizers and harsh soaps, irritant dermatitis has become very common. And these people have to either change their soaps to a moisturizer-based soap. They use a lot of hand moisturizers after hand wash. You can use cotton gloves inside the latex gloves, or you can use latex-free gloves if you've got a contact reaction to these. And with these personal protective equipment, especially masks, there is this contact which is happening between the mask and the skin, and there's a lot of humidity if you're wearing the full PPE kit. So these masks and goggles nowadays, we have seen contact dermatitis happening because of these. Then because of the pressure of the mask, acne or pimples can happen. And nasal skin changes, especially on the nasal bridge, we are seeing erythema and pigmentation, and even if you can develop ulceration and scarring there as well. So there are papers which have recommended using some small paper towel or a soft cushion, as you can see in the photograph, below the nasal bridge of the mask, and that can prevent the skin there from actually getting damaged. Secondly, the PPE kits can exacerbate pre-existing skin illnesses as well. So one is to make sure that they do the requisite remedy for whatever the pre-existing skin illness is. So in short, what I would say that there is no specific skin rash as a marker of COVID-19, but if you get a rash with other symptoms, do consider the association, but also think of differentials. And the skin protective measures are really important. So you have got the sanitizers, you've got the PPEs, the masks, the goggles, and the gloves, but then always have the protective measures at hand so that your skin remains healthy and competent. Thank you very much.
Thank you. Thank you very much, Ram. It was indeed an excellent summing up presentation.